We'll move on to the next session 2. I would like to call upon the chairpersons or the moderators, Dr. P.B. Shivaraman and Dr. B. Aisha Shaheen.
Good morning all. I thank one and all for inviting me to be the chairperson along with our stalwart Professor P.B. Shivaraman sir. And to start this discussion, I think it's a very entertaining topic. We already know that the first speaker is an all-time entertainer who keeps the audience in raptures all time, irrespective of the topic. Now, I invite Professor P. Parandaman to share his talk on male and female sexual dysfunction.
Thank you very much, Madam, for a kind words.
Sir, 1 minute. I know you are, once you take up the mic, you'll be very engrossed. So, your time slot is 15 minutes, sir.
15 minutes, yeah,
so,
yeah.
Try to condense everything within that.
Yes, yes.
Thank you, sir.
Yes, madam. Yes, sir. Thank you very much, madam. At the outset, I'd like to thank the organizers for giving me this wonderful opportunity to learn sexual physiology and pathology. And to start with, you are talking about male and female sexual dysfunction. What happens before you understand the dysfunction? Let us briefly go to the physiology of what is normal physiology and what happens in diabetes. So what can be done in diabetes? So this thing is sexual dysfunction is a secret complication. It is often neglected, under-recognized. The prevalence in men anywhere from 35 to 75%. In women is 50%. It increases with the duration of diabetes and poor glycemic control, and also with the aging. The studies found that diabetics develops erectile dysfunction 10 to 15 years earlier than non-diabetic individual, and sometimes they may not respond to the pharmacotherapy. It affects quality of life, marital harmony, and is an indicator of a vascular disease. So, this is to recapture the physiology. The sexual arousal starts. The sexual arousal is a neuropsychophysiological process occurring normally. The arousal starts in the cortex. The hormone modulates sensitivity. The wonderful hormone is testosterone. It modulates sensitivity of the cortex. This is located in the frontal lobe. It's connected to the limbic system and the hypothalamus. This control, we have 3 controls: central control, peripheral control, and the hormonal control. The central is erotic thoughts, fantasies, visual, auditory, and olfactory. A peripheral mechanical stimulation, and a hormonal testosterone which modulates the cortical excitability. For estrogen in women maintains a genital health and lubrication. So the wonderful hormone is the excitatory hormone is dopamine, and the inhibitory hormone is prolactin, serotonin. Hypothalamus acts as a master switchboard to connect between the cortex and peripheral input. So this is a normal physiology. We have 4 phases: phase 1, phase 2, phase 3, phase 4. Phase 1 is arousal, sexual arousal. For that you need a desire. To have a sexual arousal, you should have a desire. The desire is by the testosterone. The testosterone acts on the cortex. It directly stimulates the hypothalamus, increases GnRH, then LH. That LH directly acts on the testes, that is Leydig cells that produce testosterone. So it's a vicious cycle. Goes like this. So once you get arousal by the stimuli of visual, olfactory, physical, and imaginary, it stimulates the parasympathetic system. It increases the vasodilation by releasing nitric oxide. And the third phase is the sustaining the vasodilation by increased cyclic GMP, and this is called plateau phase. And fourth phase is sympathetic activation, where the PD5 enzyme inactivates the cyclic GMP, and orgasm. It is a peak or state of orgasm, the sexual act, and followed by phase 4 resolution. So what happens in diabetes? In diabetes, the mechanism of erectile dysfunction or sexual dysfunction diabetes is there are 5 things. One, the vasculopathy, maybe microvascular, macrovascular, or neuropathy, whether motor, autonomic, or sensory, or maybe a visceral adiposity due to increased aromatase activity, or maybe insulin resistance and hypogonadism, that means decreases testosterone levels. And ultimately, it increases advanced glycogen end products along with the oxidation stress that decrease the nitric oxide synthase activity. That is the one essential for vasodilatation by releasing nitric oxide. The reduced nitric oxide synthase in the endothelium of the corpus cavernosum that decreases the release of these guanylyl cyclase, thereby conversion of GMP to cycle GMP doesn't occur. That's the reason that is necessary for the erection. What about the insulin resistance? Insulin resistance is the most important aspect. The insulin resistance on 4 levels insulin resistance. One at hypothalamus level. It decreases release of GnRH. That is essential for LH and FSH and reduces testosterone. At pituitary level, again it's essential for LH secretion. That is, if it not decreases, low testosterone. It affects the testis level. It causes primary the testicular dysfunction by increasing the aromatase activity, converting the testosterone to estrogen. At a direct effect on testes, that producing the decrease on the steroidogenesis testosterone. So this is ultimately happens in diabetes. What happens? Phase 1 block testosterone, no arousal. Phase 2, phase excitability, arousal, again is not related, no vasodilatation. So 3A places it is get affected. The only thing is that once this is not initiated, subsequently third phase, fourth phase is not affected. That is a problem with diabetes. So it's all due to insulin resistance. Again, there are 3 components: neurologic components, hormonal components, and vascular components. Neurologic components, autonomic neuropathy. Autonomic neuropathy first affected is a parasympathetic, that is essential for nitric oxide release. And sensory stimulation, no gentle sensation, no stimulation. Motor, pelvic muscle weakness, specific, impaired, reduced, and altered. All these are decreased because of this neural dysfunction. The hormonal factors, estrogen. This testosterone is the most important hormone for a desire. That is reduced, as already alluded, and decreased is sex hormone binding globulin, altered LH-FSH, insulin resistance, and females decreased estrogen, progesterone, reduced androgen levels, and earlier menopause in females. The testosterone levels, what happens to normal? After age of 30, even normal individual, 1% of testosterone decreases per year. That is double if you have diabetes. That is 1.5 to 2% per year, thereby hypotestosteronemia, that is hypogonadism in test, it is if diabetes is not controlled. So, not only that, we have insulin resistant diabetes. As far as the sexual dysfunction is concerned, we have testosterone resistance at tissue level because of the insulin resistance. And vascular component, microvascular, macrovascular, we all know this. Females, everything there is, the relaxation is less and perfusion is less. So in males, it is found that decreased desire, this testosterone, it accounts for 35 to 70%, and premature ejaculation 25 to 30%, that is due to neuropathy. If we have a sympathetic overactivity, premature ejaculation. So that's and retrograde ejaculation, if you have autonomic neuropathy, no sympathetic activity, retrograde ejaculation. Hypersensitivity activity is premature ejaculation. These are in addition to the vascular dilatation. So if female dysfunction, of course, the decreased desire, decreased arousal, orgasm dysfunction, dyspareunia, all this can occur in diabetes. So what are the risk factors for this? Risk factors, anybody is having diabetes more than 10 to 15 years and poorly controlled diabetes, increasing age, increasing comorbidities, depression, medical lifestyle changes, all these are risk factors for diabetes. So this is very simplification of this thing, how this acts, whether insulin excess or insulin resistance cause oxidative stress. The oxidative stress resulting in primary testicular dysfunction in the testes, secondary testicular dysfunction in the hypothalamus, causing this pituitary, resulting in erectile dysfunction, and these are the effects of the hormonal effect. What about the sexual dysfunction in females? is in addition to the metabolic factors, hormonal factors, psychological factor, you have microbiome related dysfunction also can affect especially in females. So this is regarding the males, psychological factors, hormonal factors, blood vessel factors and neural factors, all these affects this thing. So altogether, if you all put together, these are the factors which is related to sexual dysfunction in males. So what are the commonest cause? Is diabetic agreed? Is it common? The commonest age group wise changes. The commonest in younger age, psychogenic is more common even though it's diabetic. And if it is a middle age, mixed, organic as well as psychogenic. If it is old age, organic is primarily. But anything can occur at any age. All these factors are due to this. And how this improves the sexual desire? You build up an emotional intimacy with a partner. Reduce the anxiety. Correct the myths. And avoid porn-induced desensitization. This is very, very common nowadays. Porn-induced desensitization. So no erection at all. If you keep doing that. So medical therapy is based on this thing, of course you will be dealing with. And when to seek medical help, there is a persistent erectile dysfunction more than 3 months, severe vaginismus, suspected organic cause, severe anxiety, depression, you should take help from the physician. So I'd like to point the 2 case scenarios, one for male, one for female. This is a male, 48-year-old diabetic male, is 10 years of diabetes, HbA1c was 10.5 on irregular medication. It's an IT professional with erratic food habit. It is a highly positioned man in IT, but erratic food habit due to the office work. And he's a diabetic of 2 years under control with the telmisartan once a day. Dyslipidemic on rosuvastatin under control. Presented with the premature ejaculation, erectile dysfunction for the past 6 months. So what is the problem here? So problem, phase 1, phase 2, phase 3, phase 4. Which phase is having problem? Is it a phase 1 problem, psychogenic, or phase 2 problem, organic, vasogenic, or neurogenic? I think they don't want me to continue this. So that's a problem. So whatever the function is there, so if you assess this, yes, having the problem is decreased desire. Why? Due to stress. Decreases testosterone level because HbA1c was high, 10.5. Anything more than 8 is probably is not good. And the decreased testosterone level, thereby no desire, no visual erection, no cortical function, and of course there is no excitement and is not able to have a sustained vasodilatation because of the sympathetic overactivation because of the job nature. Is very highly positioned, highly earning, but high stress. So no increases sympathetic stimulation. And is it psychogenic or organic? We ought to do simple test. It's step 1. You for any individual with a psychogenic sexual dysfunction, you ask for is a psychogenic, organic. If organic, is a vasogenic, neurogenic. Now, if you want to rule out the psychogenic, you do a stamp test. Roller of stamp around the glands, around the staff of the penis. So you look for is it breaks in the morning. Now we have done the test, it breaks. So it is probably psychogenic. If normally is there, if stamp test is positive, breaks in the morning. The step 2 is whether he is having vascular etiology or in addition to the sexual dysfunction of psychogenic, is it organic is also mixed. So we do step is give sildenafil. That is give 50 mg of sildenafil and wait for 30 to 60 minutes and give exposure to the erratic literature, videos, and of course videos and all the pictures. So you start stimulating him. In a normal individual, it starts stimulating by 15 minutes. And the test is positive is able to attain at least 60% of the erection. If 60% of erection is necessary for the penetration, so if it is not. But what you have done the same test, it was done, its percentage is only 55%, erection is slightly poor. So not only is having psychogenic, he is having organic also, possibly vascular, but minimum you should have 60%, but he is having only 55%. Probably his problem is a mixed pattern, psychogenic and organic, for vascular. So for after revealing out the vasogenic, is there neurogenic? So what you do is, a simple test, you do the bulbocavernous reflex test. You squeeze the glans penis and you look for the anal sphincter contraction. So that is intact. So there is no neuropathy, but there is a minimal vasculopathy and psychological disturbance as well. So the patient was, and of course you have a novel the test ratio. This is called something called platelet lymphocyte ratio. That is it is a novel biomarker for erectile dysfunction, but normal it is 110 to 120 is a normal. If you take the platelet, so NLR ratio, what you take for the COVID, you would take like the PLR ratio for sexual dysfunction. It is a reflex endothelial dysfunction, and normal is 110 to 120. This partial patient is, if anybody is having more than 130, it's a vasogenic erectile dysfunction. The patient value is when we are putting 119, so slightly lower limit. So this includes is a possibly there is a marker, it is a vasogenic potential is there. And management, the dapagliflozin is a 30 milligram before intercourse. This is a very, very wonderful drug for erectile dysfunction, especially the premature ejaculation, because it is short acting, it does not have any side effect on this, and this can be used on demand basis. Of course, alternate therapy you can use paroxetine, but that is the most effective in this case. So second case is a female of a 34-year-old, migraine, 8 years, and hypertensive to 6 years, primary hypothyroidism 5 years, and married 5 years, having one kid 3 years, but not having sex for the past 1 year. That was a complaint by the husband. So he came, presented, he was on premixed insulin 30-70-20 units in the morning, 10 units at night, metformin 500 BID, dapagliflozin 10 mg OD, telmisartan 1 OD, and propranolol for migraine headache, amitriptyline for migraine headache, thyroxine for hypothyroidism. So that was solution. And the investigation done outside was HbA1c was around 10.5, blood sugar raised, TSH elevated, prolactin is elevated. So why the prolactin is important here? If you have the low thyroid hormone levels, T3T4, it directly stimulates the hypothalamus, release the TRH release the TSH, along with the TSH, prolactin release, the prolactin inhibits the sexual desire. So this is a mechanism, so that we have done it. And of course, insulin is not a neutral, it does not have any effect on the erectile dysfunction. Recurrent hypoglycemia, the patient was having recurrent hypoglycemia, keep taking food frequently, but scared of the excitation and sexual can reduce the sexual desire because of the hypoglycemias. And SGLT inhibitors, if recurrent genital function, patient is scared and may have dyspareunia and of course decreased libido also. Thiazide, this is the most important drug, it should be avoided, and this cause decreased vaginal lubrication, decreased libido, decreased orgasm, and all this can occur with the thiazide, and patient is already taking. Propranolol is given for a headache, migraine headache, that decreases libido, decreases arousal, decreases entire all phase it acts. And amitriptyline, again the antidepressant, decrease the vaginal secretion, increase sedation, all this. So all these drugs what is being on as these sexual drugs. So that is there. Hypothyroidism not under control, so we have to step up those. Hyperprolactinemia is there. See, again that is by the GNS. So these are things are there. Now this patient problem is diabetes, not only diabetes, drug-related dysfunction. There is psychogenic dysfunction and dysfunction organic, drug-related this sexual dysfunction. So it is limited. That they found that. The question is that we have found that it is only psychogenic. We remove the drug and patient become all right. Now the next question is, what are drugs we can? What are the food you can take, doctor? That is the next question. Dietary advice for doctors. Very simple. There is drumstick leaves. See, if you go through literature, drumstick leaves demonstrate anti-androgen. There is the demonstrated the direct androgenic effect. It increases testosterone level by 35 to 45%, and it is very stimulant effect on the human chorionic gonadotrophin. So Murungakai is very important. Murungakai and the Murungakai seeds, methanolic extract. See the methanolic extract, corpus callosum muscles. It improves the erectile function. The rats. It is doing for rats. You won't do for man also. There is human also. See, rat model shows it has got PD5 inhibitor effect. Murungakai, right? PD5 inhibitor effect, and it also inhibits the MAB inhibition. Increases testosterone levels in the index cells directly. See, very wonderful the Murungakai we have. And see, is a desire, cerebral cortex. Again, once you have wonderful testosterone levels, you'll have wonderful sex. So that is done by Murungakai. So not only that, there are so many aphrodisiacs commonly available. We feel hesitate to talk to the friends about the aphrodisiacs. Yes. So these are things, almond, or these are the pharmaceuticals, L-arginine and zinc. Zinc is very important for test. There is spermatogenesis, pyridoxine, that improves the absorption of zinc and this thing. All the testosterone levels are increased. Okay, arginine is all increased. So friends, what we do? Prevention of sexual dysfunction. How to prevent it? Plan it early. Don't try to prevent after it is developed. Plan it early and prevent it by doing all these things. What is the solution? Primary prevention. What is the primary prevention? Start it early. Even before you develop diabetes, you start it early. So no sexual dysfunction throughout the life. Friends, take up messages. Or the sexual dysfunction in diabetic men is mixed, most from 30 to 40%, and women is 50%. Sexual dysfunction increases with duration of diabetes and progressive if we don't respond even to the drug, if it's a vasculopathy is there. And screen all diabetic patients for sexual dysfunction annually. Don't take it granted. Please screen for it. Optimize diabetic control as is a foundation of treatment for sexual dysfunction. And consider both partnership treatment and planning. Remember, the sexual health is an integral part of overall health and diabetic care. Start preventing measures early, simple lifestyle modification, even before the patient develops diabetes. Thank you very much for patience.
Thank you, sir. That was
We
a very
kindly
wonderful
request the
presentation.
speakers to be on time. Don't steal others' time because others it will be delayed. Please, yeah.
That was a wonderful presentation. I think you have covered all the aspects. One thing in females and even in males, I think you have not mentioned about the urinary part, which plays a very integral part in most of the cases of sexual dysfunction, particularly moreover in the females. Urinary incontinence, when put on medications, usually you have an overactive bladder in diabetics. So the medications following this and coital incontinence can be one of the prime causes for sexual dysfunction in the female. Thank you, sir.
Thank you.
Now I call upon Dr. Prashanthi Arun to talk about assessment and evaluation of sexual dysfunction.
Me here today. I think after Parandaman sir spoke, the lunch is going to be full of murunka varval, murunka sambar. I think Green Park is ready for the murunka after this session. So, sir has given a heads up about the sexual dysfunction and he's actually gone little into the assessment and treatment also, but I'll be touching up something a little broader spectrum. So if you see the prevalence of sexual dysfunction in India, in men, it says erectile dysfunction is around 60.73%. And in a study in North India, it says that sexual disorders prevalence is around 48.4%, which is really very important, can't be missed. But usually it's overlooked in women, but it's very important for having a, I'm sorry. I didn't know. I'm sorry, I think the timer starts again then. Huh? So the prevalence of erectile dysfunction in India in a study from Manipal is around 60.73%. And the prevalence of sexual disorders in another study in North India was around 48.4%. And women, it's usually overlooked. But what happens is it affects the quality of life and the relationship satisfaction. So either the one is affected, unfortunately, the problem is for both of them. And as already sir had already showed the figures of prevalence of sexual dysfunction in women, 50%. Again, there's another study shows it's somewhere between 20 to 80%. So average, yes, 50%. And the global prevalence of sexual dysfunction is around 61.4%. Be it desire, arousal, satisfaction, erectile problems, whatnot. And usually, the study says that male have a higher prevalence of sexual dysfunction compared to females, and people with diabetes have a higher prevalence of sexual dysfunction compared to people without diabetes. I think sir has beautifully explained the reason for it. So when you talk about types of sexual dysfunction in men, we've got the erectile dysfunction, premature ejaculation, retrograde ejaculation, and reduced libido and erection. And moving on to female sexual dysfunctions, we've got the hypoactive sexual desire disorder, the female arousal disorder, decreased lubrication, dyspareunia, female orgasmic disorders, and vulvodynia. So the American Diabetes Association Standard of Care 2025 recommends in men with diabetes or pre-diabetes, it's very important to inquire about their sexual health. And in case symptoms of hypogonadism is present, then morning serum testosterone levels measurement is very important. Again, in men with diabetes or pre-diabetes, screening for erectile dysfunction is important, like we screen for other cardiovascular disease, kidney, heart, etc. And in females, it is very important to ask about their sexual health, and importantly, in post-menopausal women, it is very important to screen for symptoms of genitourinary symptoms of menopause. So this is a clinical and self-grading tool which will help us know whether the person has erectile dysfunction in men. It's actually very simple. I think people in the crowd also can go through it and do it if they want to, but it's just a simple questionnaire. We can just give it to the patients, they can tick, and with the score we can know. It's a validated questionnaire. It's the 5th International Index Erectile Function. It's a set of 5 questions, and out of these 5 questions we've got a rating between 1 to 5, and the question is like, how do you rate your confidence that you could get and keep an erection? When you had an erection with sexual stimulation, how often were you erection hard enough till penetration? During sexual intercourse, how often were you able to maintain your erection after you had penetrated your partner? During sexual intercourse, how difficult was it to maintain your erection to complete the intercourse? When you attempted sexual intercourse, how often was it satisfactory for you? It's just simple 5 set of questions, and the rating is between 1 to 5. And this scoring is, if your scoring is somewhere between 5 to 7, you've got severe erectile dysfunction. 8 to 11, it's got moderate erectile dysfunction. 12 to 16, mild to moderate erectile dysfunction. 17 to 21, mild erectile dysfunction. And if it's between 22 to 25, it says that he's eaten well murungaka, it's no erectile dysfunction. So going to the women part, we've got 2 validated score like for the men. It's the FSFI and the FSDS. So female sexual function index and the female sexual distress scale. Here it helps us identifying who's at risk, but we cannot take this up as a diagnosis. So the FSFI questionnaire is a set of 19 questions. In interest of time, I'm not going to go through of every question, but again, this 19 questions are again categorized domain into 6 categories. So first 2 questions fall under the domain of desire. 3rd to 6th question falls under the domain of arousal. 7 to 10 falls under lubrication. 11 to 13 falls under orgasm. 14 to 16 falls under satisfaction, and 17 to 19 falls under pain. So interpreting this FSFI as each domain has a minimum scoring and a maximum scoring of up to 6, and each domain last we get a score of maximum totaled together 36 or a minimum score of 2, and any score less than 26.55 indicates female sexual dysfunction. So this is very easy. You can just pass on the questionnaire to the patient who's coming, be it men, give them the other one, females give them this, and once they know, we can decide on what to do next. Next is the FSDS. This is a 13 question, again grading between 0 to 4, and the total number of this scoring is around 52, and anything more than 11, then definitely the patient has female sexual dysfunction. So these are about the questionnaires to know whether the person has sexual dysfunction or not, and then we move on to the investigations that are available. I'm touching upon a little. So again, as the validated questionnaires are over, post which we've got the nocturnal penile tumescence, we've got the penile Doppler, we've got the dynamic infusion cavernosometry, the corpus cavernosometry, and other imaging techniques. So the penile ultrasound is a non-invasive test that uses sound waves to know the blood flow within the penis, helping us diagnose erectile dysfunction. Then we've got the nocturnal penile tumescence, which helps us determine, this is a test done in the sleep that helps us determine whether the erectile dysfunction is physical or psychological. As sir was already saying, we have to differentiate the organic causes as well. We've got the dynamic infusion cavernosometry and the cavernosography. It uses both pressure-based and imaging-based techniques to evaluate the vascular functions of the penis in cases of erectile dysfunction. Now moving on to females, we've got the vaginal pH and the vaginal maturation index. So a low vaginal maturation index and an increased vaginal pH is indicator of vulvovaginal atrophy or genitourinary syndrome of menopause. So the patient might have dryness and other symptoms. We've again got Doppler ultrasound to assess the clitoral blood flow to evaluate the female sexual dysfunction. And we've got other sexual dysfunction tools assessment like the vulvoscopy, the biothessiometry, perineometry, etc. And diagnosis of the female sexual dysfunction should be number 1, physical examination, pelvic examination, vulvar and vaginal examination, breast examination, neurological examination, hormonal evaluation, follicular stimulating hormone, luteinizing hormone, because luteinizing hormone is to assess the ovarian reserve and the menstrual cycle with hormonal balance. Sorry, the follicular stimulating hormone lets us know the ovarian reserve, and the luteinizing hormone is to assess the ovulation. And neurological examination of the motor system, sensory system is very much important. Breast examination for any kind of lump or pain is definitely important. And in general, a genital examination is very much appreciated. So apart from dealing with only erectile dysfunction, female sexual dysfunction, ED, we have to look up on the general condition of the patient, because if the patient's general condition is fine, his sexual health is going to be normal to an extent. So look at his HbA1c, CBC, lipid profile, prolactin, thyroid function test, testosterone levels, the LH, FSH and the estradiol levels. So hyperglycemia could be a direct driver for neuropathy and vasculopathy, anemia which can contribute to fatigue and reduced sexual desire. Lipid profile dyslipidemia could be a contributor to endothelial dysfunction and atherosclerosis, and an elevated levels of prolactin can suppress libido and cause erectile dysfunction. Hyperthyroidism and hypothyroidism can lead to sexual dysfunction. Low levels of testosterone levels cause low libido and erectile dysfunction. So moving to our very own Indian guidelines, what the RSSDI guidelines say for sexual dysfunction for men. Next we have the women. So prolactin and thyroid function test should be considered before going into measurement of testosterone levels. And testosterone levels are to be tested in a good lab, but before 11 a.m. Patient should be made to understand the difference between erectile dysfunction and premature ejaculation. Adult men with diabetes should be screened for sexual dysfunction, erectile dysfunction, etc. from the time of diagnosis. So at the time of diagnosis, we definitely do ask them about the eye, heart, kidney, leg. So we have to talk about the erectile dysfunction also to the patient. And detection of erectile dysfunction and evaluation and response to the treatment should be used with validated questionnaires. This is one of the validated questionnaires that I was discussing, the IIEF scoring. And interest, maybe a lot of people will have lack of interest, etc. So definitely a psychological counseling is very much important to find out organic causes. Now moving on to women, what the RSSDI guidelines tells us is history is always important, and using of validated scorings, which is already what I was discussing, the FSFI and the FSD scoring. And next, in postmenopausal women, it is definitely important to check their mental status while they are coming for their routine clinical practices, and we'll have to evaluate them for cardiovascular, kidney, same for female sexual dysfunction as well. So currently the therapeutic recommendations for female sexual disorders include maintaining a healthy lifestyle, achieving a good glycemic control, genitourinary infection control, etc. So as I told you, healthy lifestyle is very important to be sexually active apart from the Murungaka. And take home message, sexually dysfunction is common, but it's very under recognized complication of diabetes, because we all ask how is your eyes, how is your kidney, how is your... Nobody asks how is your sexual health. I don't know, the patients don't come up also. So we have to make it comfortable for them, because sexual life, definitely a person is going to be happy there, he's going to be happy in his life. And if one partner is affected, it doesn't stand with one. If one is affected, the other is obviously affected. If he doesn't have any extramarital affairs, impact of both men and women affecting quality of life and relationship is very important. Screening tools, our validated tools have to be really used. Management should be multidimensional, medical, psychological and lifestyle related. Addressing sexual health is essential part of comprehensive diabetes care. Thank you so much.
Thank you.
I finished in 11 minutes. I've spared 4 minutes. Thank you.
That was very Very nice of you, sir. Now I call upon Dr. Palnikumaran to present his talk on androgen deficiency.
Very good morning, everyone, and thanks the chairpersons for introducing. And sincerely thanks Dr. Shanmugam and the organizing team for giving me the opportunity. So my topic will be a good old topic, but still now it's being a controversial topic. That is androgen deficiency in aging males. So in mnemonic you can name it as ADAM. So my agenda will be going on through these headlines. So ADAM is actually age-related decline in testosterone hormone. So still there is a controversy exists that it could be a normal aging phenomenon or it's a true disorder which has to be addressed. And recent evidences clearly says that raising testosterone to normal levels has some benefits which has been documented and evidenced, and it has to be addressed to all the patients. And coming to the epidemiology, the prevalence, depending upon the current diagnostic criteria, it has been claimed that it's up to 12% in men of more than 40 years. And once again, it's an underdiagnosed and neglected condition, both in point of doctor's view as well as patient's view. So various terminologies has been described for this age-related testosterone deficiency. One is andropause. Andropause is similar to that of menopause. The contrast between menopause and andropause is actually andropause, there will be gradual decline of testosterone, whereas in menopause there will be abrupt destruction of deficiency of the gonadal hormones. And the current terminology which is being favored is the late onset hypogonadism, which is the preferred one and it has been approved by universal standards. Other names are male climacteric syndrome and ADAM. So coming to what's the definition for LOH, that is late onset hypogonadism. With the advancing age, two main parameters should be there. The patient should be symptomatic in regard with low testosterone and the deficiency, the documentation of biochemical documentation of deficiency in testosterone. So these together, two components should be there in an aging male, then we can label him as late onset hypogonadism or ADAM. If we point about testosterone, 95% is produced in testis, that is Leydig cells, and they are controlled by a feedback mechanism by the pituitary hormones as well as hypothalamic hormone, that is LH, FSH and gonadotropin releasing hormone. And this testosterone is available as 2% only as a free form, and they will be bound to a sex hormone binding globulin which is roughly about 44%, and this binding is more strong, which whenever there is an increase in sex hormone binding globulin, the free available testosterone will be low, and 54% of the testosterone will be bound with albumin, which is weakly bound. And this is the feedback mechanism we all know. So GnRH influences the LH and FSH release from the anterior pituitary, and this LH influences the Leydig cells to release testosterone, and this testosterone has a negative feedback over the GnRH. And the functions of testosterone, we know that, thank you. It also helps in spermatogenesis, hair growth, it improves the bone density, it improves the muscle mass, and it's a useful hormone for libido and also improves secondary sexual characters. And to be active, this testosterone should be converted to dihydrotestosterone, which is the biologically active form, by an enzyme called 5-alpha reductase at the target organ level. So there is evidence that roughly 1% of testosterone level is being reduced per year after the age of 40, and there is also a loss of circadian rhythmicity of the testosterone secretion. And there is a notion that with the aging, this steroid hormone binding globulin increases. So this decreases the free testosterone levels, and also there will be diminished gonadotropins with the age advances. That's why this ADAM, age-related decline, is being acclaimed to both primary and secondary hypogonadism. So both components are there for this age-related decline. So coming to what are the causes, why it occurs? Why it occurs? So as clearly said, age is the main factor, age-related decline, and this age causes the Leydig cell aging also, which increases the oxidative stress within the intracellular Leydig cells. This causes atrophy of the Leydig cells, and by this way the testosterone secretion level may come down. So other factors which are contributory are lack of exercise or weight training, increased stress and lack of sleep, and there is a bidirectional relationship between insulin resistance and weight gain. So insulin resistance and weight gain actually causes low testosterone. Similarly, low testosterone causes increased amount of insulin resistance and weight gain. Other causes which may contribute to hypogonadism are OSA, depression, COPD, diabetes, rheumatoid arthritis, renal or liver cell disease, and certain drugs are notorious to produce hypogonadism such as opiates, glucocorticoids, ketoconazole, spironolactone, and finasteride. So we have to identify who are all symptomatic for this low testosterone. For this, we need to have what are the symptoms of hypogonadism. So decreased libido is the most common symptomatology for low testosterone. Apart from that, the patient may have decreased muscle mass and strength, decreased bone mineral density, which causes increased risk of fracture. This can be assessed by the estimating BMD of the heel. And depression may be one of the feature. Fatigue and decreased vitality, increased body fat, especially abdominal obesity, hair loss, and evidences of insulin resistance, diabetes per se, and sleep disturbances, anemia. So all these features can be the consequences of low testosterone in the aging. So this is the picture depicting bidirectional relationship between this low testosterone, which causes increased activity of the lipoprotein lipase. This causes increased uptake of triglycerides and increased fat mass, and wherein which this fat mass increases the insulin resistance, and this increase in fat also causes increased aromatization, and which causes increased estradiol. This further suppresses the hypothalamic pituitary axis. By this way it can cause low testosterone. And this increased fat mass actually also causes increased leptin and pro-inflammatory cytokines, which all will increase the leptin resistance and insulin resistance. So this is the bidirectional relationship between low testosterone and insulin resistance. So the diagnosis, as I already have told, so it depends on both the symptom as well as biochemical evidence. Both should be there. Patient should be symptomatic as well as there should be an evidence of low testosterone. And a lot of diagnostic challenges are also there. Because as already told, the overlap between normal aging symptom may be there. Certain uncertain, the reference ranges are not to be they are uncertain, and assaying the testosterone is also variable. And always we have to use the young adult male range for reference. And who should be tested? Those elderly having symptoms or consequences of low testosterone. And for symptomatology, we can use this Adam questionnaire. So these are all about symptoms of low testosterone. 10 parameters are there. Even one single parameter indicative of sexual function is significant, and we can take it as symptomatic. With the evidence of lab investigation, this testosterone should be estimated in the morning, ideally in fasting state, and the cutoff level is 8 nanomole per liter. If it is below than that, we can label them as hypogonadism. And the test should be repeated at least 2 times to document that the patient is having unequivocal low testosterone. And the method usually preferred it should be a standard method, that is liquid chromatography or mass spectroscopy. And LH levels can be done to differentiate between primary and secondary. Prolactin level can also should be done if the testosterone is very low, that is less than 5 nanomole, and BMD can be done. So coming to the management, are we having management? Yeah, definitely. It's an easy, safe and effective way of managing this hypogonadism, that is low testosterone. But it is indicated only when the testosterone is confirmed equivocally low with symptoms of low testosterone. And the benefits, what we acquire from this replacement. So definitely we can see an increased lean body mass and decreased fat mass and increased grip strength. And there is some amount of some moderate improvement in sexual function, especially libido and mood, but not in erectile dysfunction. Improved vitality has been documented. There will be mild improvement in cognitive function and definite improvement in anemia and also BMD. So these are the benefits which has been evidenced in the literatures. And various forms of testosterone therapy are available. Oral form is undecanoate, but what we prefer is IM injection, that is short acting and long acting. Gels, transdermal patches and pellets are also available. And the target testosterone to be attained is low normal range, that is 10 to 30 nanomole alone, not higher than that. And these are the various forms, and we usually prefer this IM form. It is 250 milligram every 2 to 3 weeks till the, and the testosterone level should be estimated at least biannually. So the risk of this testosterone replacement therapy, they may have a possible obstructive symptoms, obstructive LUTs, especially by increasing the benign prostatic hyperplasia. But it's not, a lot of literature has to be evidenced for this correlation. And definite risk is the polycythemia. It can raise the anemia and it can raise the HP level, and sleep apnea is also one of the risk factor. And there is possible concern over the increase in the risk of prostate cancer progression. So it is contraindicated in if the PSA is more than 4 or family history of CA prostate. And there is also concern in the cardiovascular risk. It actually increases the coronary artery plaque, but the clinical cardiac event is not so much raised. So a lot of studies has to be done on this aspect, whether this increase the cardiovascular risk or not. So how are you going to monitor the therapy? So always check testosterone level at least biannually, monitor the symptoms whether they are improving or not, and definitely you have to monitor prostate PSA and DRE, digital rectal examination. If PSA crosses 4 or exceeds 1.4 than the baseline after 6 months of the therapy, TRT should be reconsidered. And always monitor hematocrit, CV risk and sleep apnea. And the contraindications, absolute contraindications of prostate cancer and relative, whenever there is a high prostate cancer risk or untreated OSA, severe heart failure and significant polycythemia, you have to avoid TRT. Apart from the testosterone replacement therapy, we have to also follow lifestyle modifications such as weight loss, regular exercise, moderate alcohol intake, smoking cessation, and reduce the stress and improve sleep, which will improve the hypogonadism in the aging male. So to summarize, late onset hypogonadism requires both symptoms and low testosterone, and the prevalence is roughly 12% in men over 40 years, and TRT benefits in muscle and fat composition and some sexual functions. Risks are also there with the increased risk of prostate cancer, and if any uncertain clinical situations arises, endocrinology referral should be done. Thank you for your attention.
Thank you. Now I call upon Dr. Venkatakrishnan to present his talk on psychogenic and other causes of erectile dysfunction.
So good morning everyone. So thanks DAISICON team for the opportunity given. And thanks once again because my job is made easy. Most of my topic will be an overlap of what we learned, followed by the management strategies, the last talk of this session. So anyway, let it open. It will be easy for me to without slide also. So what we should know about psychogenic causes. The topic for me was psychogenic and other causes. So almost all the other causes have been listed by other faculties, and specifically by Professor Prandaman sir, who mentioned about all the various aspects of erectile dysfunction. Psychological cause. So if you say why this topic is important is, whatever is the pathophysiology, coming to the pudendal nerves, erection, before that what are the vasogenic causes, what happens to the vascular, what happens to the brain is more important. In the brain, what are the structures involved which are specific for having a sexual desire, and what are the hormones involved? Without that, whatever is the other pathophysiology, the primary is from the CNS. That's what we are going to discuss today. So we should know multiple regulatory hormones are involved in erectile dysfunction. What happens is, the first one is sinusoidal. Is the pointer working? Sinusoidal relaxation. Is it working? Pointed? No. So no problem. Sinusoidal relaxation, arterial dilatation and venous compression. These are the three. That's what is erection. Initial sinusoidal relaxation followed by venous compression. Everything has been discussed starting from hormonal, neurological, vascular and cavernous factors. But this is usually a combination. There is not a single cause in any patient. we usually have a combination of various factors that cause erectile dysfunction. What I am going to stress upon with this pathophysiology is the third one. Impaired neurogenic vasodilatation. That is what is the core of a psychological cause of erectile dysfunction. Around 40%. Definitely, it's a big number. Interestingly, you can see the psychological effect is more in young males. With increasing lifestyle changes, young males have more psychological causes. If somebody comes with erectile dysfunction, especially young and middle age, always first you should rule out a psychological cause. So multiple list is there. I am not going to read everything. So we all know what it is. Starting from marital issues, cultural norms, expectations, loss of self-esteem, shame, anxiety, depression. ED can cause, when there is a effect of ED, one exposure that there is no erection, that itself compounds the next issue. That's what affects the quality of life. Now, interesting, the last point is very important. Most often it is treatable. That is a positive aspect. The other causes is the topic is everything is discussed. Everything was discussed. I am not going to this. What here is I will stress upon is sleep. Sleep is the most important among all other causes. What sleep does will be the next slide, and what are the core areas in brain which are involved in erectile dysfunction, which is affected by a psychological cause. So if you see, so point I can do is, these two are most important. You can see medial preoptic area and paraventricular nucleus. These two are in the hypothalamus. Sorry, thank you. So these two are in the hypothalamus. You can see this is for sexual partner recognition, hormonal sensory cues integration. This has estrogen, prolactin and progesterone. PVN is basically oxytocin. It is classically involved with increased penile erection. So hypothalamus is the major area. These two important areas control erection. Next, coming to forebrain. Sexual motivation, decreased sexual drive. If there is a issue with the piriform cortex lesion, you have a decreased sexual drive. Sexual motivation, amygdala, stria terminalis. Erection, as I told you, PVN, paraventricular nucleus, hippocampus. Arousal is right insula and inferior frontal cortex. Again, left anterior cingulate cortex coordinates sexual arousal. Apart from PVN, there is a separate nucleus, paragigantocellular, which is in the brainstem coordinating decreased penile erection. If this is not properly functioning, if there is a good function, you have a good penile erection. Not functioning, there will be a decreased penile erection. Non-adrenergic innervation to perineal smooth muscle, A5 catecholamine cell group and locus coeruleus. So these are important, where a psychological cause can induce hormonal imbalance. With this is the initial requirement. There should be a sexual desire, motivation. Without that, all others did not, what all we discussed, the previous speakers, is not going to happen. So that is, psychological is the basis. Next slide is on neurogenic ED. What is worrying about neurogenic ED is very tough to treat. If there is a neurogenic ED, there will be limited options except you have cyclic GMP agonist, or you go for device therapy or direct cavernosal injection. That will be discussed by the management strategy. I am not going to do that. What you should know is, if there is a neurogenic cause, very tough to treat. You are not going to treat the patient. It will be difficult to treat. So this was discussed. Why I put this is, with all into this obesity and metabolic syndrome. This obesity and metabolic syndrome will contribute to everything. When the patient is obese, all are accelerated. Starting from atherosclerosis, endothelial dysfunction, arterial changes, impaired flow, excessive outflow, and veno-occlusive dysfunction. What are the drugs that cause erectile dysfunction? So this is the very important. When you give a antidepressant, you should know which antidepressant should not be given. We have tricyclic antidepressants and MAO inhibitors. MAO inhibitors are not classically used now. TCAs are used. If you feel there is a erectile dysfunction, better avoid this group of drugs. You should go for a selective antipsychotics or antidepressants which have less effects on the penile erection. If it is young age, they may not be. Now we are seeing young hypertensive patients, young patients we are seeing who come with, because of their lifestyle changes. Beta blockers we always know they can cause. Hydralazine, it's only in cardiac failures, specific cardiac failure patients we use. Hormones, excess hormones therapy can alter the hormonal balance. As diuretics, thiazides and spironolactone. Spironolactone is definitely any liver disease patient or you are using for cardiac failure may cause dysfunction. Sympatholytics, what we are using now is clonidine, methyl dopa and reserpine is not used. Barbiturates is only for seizures, sometimes sleep disorders used. Digoxin and ranitidine may cause sexual dysfunction. So what does sleep do? Very important. If you don't sleep for 6 hours, you will not have any sexual desire. So whoever has a night shift, nothing can be done. You have to counsel him how to improve his sleep. Sleep is the most important thing. Sleep and sleep disorders will be the next. We are seeing two important disorders. The next 5 to 10 years, there will be almost a pandemic. One is the fatty liver disease. We call it MASLD. We are seeing increased incidence because of various reasons. Even late night dinner will cause a fatty liver. The same thing, if you don't have a good quality of sleep, and sleep disorders, obstructive sleep apnea also is at risk for decreased sexual desire. So what happens with the short sleep duration? The next one is sleep duration. You have to sleep with the correct cycle. The exact cycle as per various articles, it is not practically possible is what we are doing 30 years back. Still in villages they are following 6:30 dinner, 7 o'clock they sleep. They get up at 4 o'clock. That is an actual cycle. You sleep from 8 to 4. It is practically not possible. At least you sleep at 10 o'clock, get up at 5 or 6. 6 hours of good sleep. If you sleep, so you have some work, sleep at 1 o'clock, the secretion of various hormones are disturbed. Even if you have a sleep from 1 to 8, your sexual desire and other aspects may come down. That's what is very important in the sleep cycle. What happens is, as I told you, we have discussed the two important nucleus, VPN and preoptic medial area, where hypothalamus, brainstem, all we discuss, and prefrontal cortex, all will be affected with the short sleep duration. What happens is, there is a hypothalamic pituitary axis overactivity, which causes increased cortisol secretion. How many more minutes is there? I will complete, no problem. Inflammation, stress. Yes, okay, time is there. Autonomic nervous system imbalance, causing increased catecholamine secretion and vasoconstriction. Aberrant serotonin receptor and lower testosterone is the reason, the basis where there is short sleep duration. You have a low testosterone secretion, which definitely causes endothelial dysfunction and cavernosum hypoxia. ultimately there is a significant erectile dysfunction. So at least after this talk, we all will, even I am not sleeping properly, I have to accept that. We will be getting calls. Still, we can always improve on that. So this, why I wanted to put, anyway, it will be discussed by the next speaker. This is when there is a sexual stimulation. That is what is the prime. So CNS should be clear. So psychological issues should not be there. Followed by nitric oxide, I am not going to this. You can target, these are the areas you can target even in a psychological. If it is a psychological erectile dysfunction, the good point is 100% it is treatable. The patient will come back with a good counseling. So therapy, only boring therapies, always counseling, psychotherapy, I am not going to details of all. Relaxation techniques, we should always have a good class on yoga, or you learn yoga, meditation. Medication for managing psychological, as I told you, you should choose antidepressants which will not worsen or exacerbate a erectile dysfunction. To summarize what we learned today is, majority of ED is psychogenic. 40% is a big number. So I can even put it as next 60 to 70% in young adults, because of their varying lifestyle, night shifts, and egoism, self-esteem, all are there. You can see everybody is coming to the clinic. New diabetes, young diabetes are seen because of sleep disorders. They have a circadian rhythm which is altered. Drugs and sleep disorders play a major role. That is the next point. And what we learned is neurogenic ED, very tough to treat, and it is a different pathophysiology. The last one is, any erectile dysfunction due to psychogenic cause is psychotherapy only. If at all he has a specific depression issue or other psychiatric issue, it has to be treated. Thanks once again for the opportunity. Any questions will be welcome.
Now to talk about the management strategies, I call upon Dr. V. Ravi.
A very warm good morning to everybody, and first of all thank Dr. Shanmugam and the team for giving me this opportunity. And you know pretty well all the previous 4 speakers have given you the overall view. Yes, the basic pathophysiology that is involved in sexual dysfunction, and the assessment plan, and all this hormonal pathways, everything fully and full thing. So we will straight away go to the management strategy. Very simplified கொண்டு போயிடலாம். நிறைய cyclic GMP and the pathway நிறைய loaded with all the subjects for the past 4 lectures. We will straight away go to the management strategies of the sexual dysfunction. So how we are going to plan? Before planning of management strategies, what you should do, you should really know whether actually which problem the patient has got, whether it really has got a sexual dysfunction or not, and if it is primarily a psychogenic or the organic cause. And if the dysfunction is an organic cause, if there is any physiological, psychological overlay is also there, and vice versa. Both the things should be assessed, whether the organic causing the psychogenic erectile dysfunction or the psychiatric problem that causes the sexual dysfunction. And if it is more than one or more than 1 or 2 functions, then which is the primary one, whether the erectile dysfunction, which is primary, whether the patient is not getting the arousal or desire or even the erection and everything. So we have to assess which is exactly the causing the problem for the patient. And as the patient has any comorbid psychiatric illness, all to be planned before that. So the principles of management: inform the patient about what you are going to do. You assess the patient and you formulate the treatment line, which I am going to tell you, and choose a plan of action, what you are going to do, and tell to the patient, have a shared decision making, and then go for the treatment plan with the concurrence of the patient. Probably what they say in literature, document the mutually agreed treatment goals. It's very, very important. You have to document what you are going to do, whether you are going to interfere with the oral therapy, or are you going to do some mechanical intervention for the patients, like a mechanical rod fixation, or whichever the type. You are going to have a vacuum therapy. So all these things to be discussed and documented properly in your case sheets. So one of the main things, art of history taking is very important. Discovery of the problem, and you have to make the patient comfortable, and careful and tactful elucidation is needed. And the choice of terminology is very, very important. The words that you are going to use is also very, very important. And the patient, what they tell is also important. What is exactly, he may tell, sir, I have become impotent, sir. Impotent enna meaning nu theriyadu. There are so many problems involved in the impotence, which I am going to tell you. And we have to really say, what is it? Do you get a desire? Or do you have the desire to go for a sex? That's the main thing. Then after that, okay, if you involve in sex, are you getting an erection? And if you get the erection, are you getting a proper ejaculation? And the ejaculation is a premature, or it is not coming out at all. It's a retrograde. So all this terminology should be clearly focused and get the point what the patient. ஒவ்வொருத்தரும் ஒன்றா சொல்லுவாங்க, திடீர்னு வேகமாக premature ejaculation கூட they may call a sign impotent. I have become impotent, sir. Why? It comes very easy. Are you getting erection? Yes, I am getting erection. Are you able to ejaculate? Yes, I am able to ejaculate, sir, but very fastly, sir. So that is not purely a sexual dysfunction, but we have to concentrate on more. We have to, because the treatment plan differ. Okay. So these are the things that we had to elicit, and social history and medical history all to be evaluated properly. And if you see there are problems in the relationship, stress factors, anxiety, guilt or anger, and the physical problems. You know, the treatment options are many. General measures, improve the diabetes, hypertension, lipid controls, as usual. Ask the doctor, any other thing, no? Nausea, vomiting, diarrhea for any drug in side effects, we know. BP, sugar, cholesterol to be controlled. And alcohol restriction, smoking avoidance. And withdraw the drug, causative drugs with the previous speakers have clearly shown. Beta blockers mainly prescribed. No, that's one of the thing. Propranolol is one of the main culprit causing erectile dysfunction. And sexual education discussion and relaxation exercise. So pharmacological measures and non-pharmacological measures or combination of both can be attributed. And there is a Master Johnson's behavioral therapy questionnaire is also available. We can use that to analyze this. And so psychosocial therapy, medical treatment, surgical treatment are the three type of therapeutic options that are available. So if you see the treatment aspects for the patients with ED, what you have to do, you have to assess identification the erectile dysfunction problem, sexual, medical, psychological, all these things to be definitely assessed. And then the functional erectile dysfunction should be clarified with the patient. And the final line of treatment, sexual education is one of the main things that we need to focus on it. And the relaxation exercise, sex therapy, lifestyle modifications. So all these things, the line of action that we got to follow. And finally, you can see the retrial with the, we have to try with the evaluate the patient for the reason for the lack of response and improper use of PDE5 inhibitors, which I am going to tell the next couple of slides. So medical management, we have got oral agents, intracavernosal vasoactive injection, intraurethral suppository muse, and vacuum constriction devices and testosterone replacement therapy. So this is the medical management program that we are going to deal. So the PDE5 inhibitors is the first line treatment and recognized as the most satisfying and effective treatment option at present available so far. So remember, the PDE5 inhibitors work well when mechanical sexual stimulation is present. Immediately after taking the tablet, the patient will not get the erection. So never say that the patient will have a good sexual erection after the intake of this tablet. But one thing, they need some sort of sexual stimulation mechanically also. And however, approximately 30 to 35% of ED patients do not respond to PDE5 inhibitors. Many patients, come across, you prescribe sildenafil or the vardenafil or the tadalafil. They are not getting, not all the patients getting a good effect of erections. There are so many reasons beyond that. There is an inadequate dosage schedules, administration of the single dose, or lack of dosage regulation. So there are many pitfalls when you encounter the failure in achieving an erection after prescribing a PDE5 inhibitors. And these are all the available options, tablets available, sildenafil, vardenafil, tadalafil, avanafil, udanafil, and miradanafil. Commonly we use only sildenafil and tadalafil in India. So the management strategy of the treat EDE in patients with patient is having a PDE5 inhibitors non-responders. We call it as a non-responders. What are you going to do? So assess the comorbid condition, and if you see where the patient's management and counseling all should be given, first thing what you have to do is you see whether the insufficient medical attempts. So if you give a drug first time and if you see effect immediately, it will not be there. So you have to go on giving the patient so many times and so many attempts should be tried with the PDE5 inhibitors and see the results. And increased PDE5 doses. What we have to do, we have to start the therapy and achieve the maximum therapeutic target. You should not stick on to lower doses and see the effect. So you have to update the dose and go to the maximum tolerated dose of the patient. and different dosing regimens also. So we got the different dosing regimens. You can take daily also, or we can take on demand. On demand, the patient wants to have sex today, he can take the tablet on that particular day. Or we can go for a daily dosing also, which is available, and the recent studies show patient with the chronic erectile dysfunction problem, you can give a small dose of tadalafil, 5 mg or 10 mg every day, which helps the patient to go for a good erection. And those patients maintained on a slow dose of these drugs can be given a demand dose whenever they want a good sex. Okay, they can take the tadalafil 5 mg every day, and on the day of having a sex, they can have a other PDE5 inhibitors in the maximum tolerant dose. Okay, and there are different PDE5 inhibitors, as I told you before, and combined use of long-acting and short-acting PDE5 inhibitors is the latest trend. You have to give the patient tadalafil 5 mg every day, and on the day of the sex, what they can do, can give a sildenafil of 100 mg. So demand dose, daily dose with the demand dose. So both these you can combine for the non-responders. And of course, the non-drug therapeutic approach without PDE5 inhibitors are there. And the partner's role is more important, psychological intervention is more important. You have to assess the psychological factors and get rid of the patient, the psychological defect also. So all these things, it will helpful to go for a PDE5 non-responders and get the good results. So contraindication, for the PDE5 inhibitors, there is a significant cardiac events in previous 6-month study has shown. PDR should not, and retinitis pigmentosa, and the NAION also, non-arthritic anti-ischemic optic neuropathy should not prescribe these drugs. So the treatment algorithm for psychiatric problem, the previous speakers have already told. Just a small hint only, assess the patient whether psychogenic problem causing erectile dysfunction or the erectile dysfunction causing the psychiatric problem, and accordingly go for the treatment. If the psychological overlay is more, first treat that and then go for a stimulant. If the patient has got a sexual dysfunction which causes psychological problem, you treat the sexual problem first, where he will get it off. So this is the way that you can go. Other drugs are available, apomorphine, yogimorphine, and trazodone are also available. And intracavernous aprostatil self-injection pen device is also available, where the drug is loaded in a pre-filled syringe. You can just inject into the base of the shaft of the penis before the intercourse. But one of the main side of it is a priapism. The erection lasting for more than 60 minutes. So the antidote is you have to give injection of 30 mg of pseudoephedrine for the patient to get rid of this priapism. And hematoma, burning, and penile fibrosis, local infection are the very common side effects. One of the very fine drug causing a very beautiful erection, but only thing there are so many side effects which may make us to hamper the treatment modality. So next is the intraurethral suppository, MUSE, medicated urethral system for erection. It's available in the 3 millimeter of pellet, can be inserted with a triggered applicator also. There are so many contraindications in partners who are pregnant, abnormal peniles, and anatomy and hyperviscosity. All these things are side effects, contraindications. The side effect is the penile pain, urethral bleeding. It is very, very difficult to go for a MUSE system, but it's one of the methods to have a good amount of erection, the MUSE system. And this is the vascular constriction device, where you have to increase the blood flow to the corpora cavernosa and restrict the venous outflow. So this is the basic principle of this treatment. So you have a constricting band and a vacuum also. You apply it, and you create a vacuum. Automatically the penile flow will be increased, and if you have a constricting band at the base, the venous outflow will be restricted, so that the penis get a good amount of erection. And this vacuum pump, this is one of the device. Attach the vacuum pump, produce a negative balance inside, automatically the penile flow will be more, and the constricted band can be applied to the base of the penis so that the venous outflow is restricted. This is also one of the methods to go for a erection. And of course the topical transdermal patches also are available, minimizes the both systemic exposure and tissue traumatization. And soft enhanced percutaneous absorption technology give ground of optimism, and prostaglandin E1 and SEPA are effective in almost 80 to 90% of the patients. Of course, the testosterone therapy, the previous speakers has already told, this is a transdermal administration has developed recently, and this testosterone applied daily to the abdomen or back or the thighs or the arms also. Of course, the nitroglycerin and the nitric oxide donor and the minoxidil ointments have met with only minimal success. They also were tried. Minoxidil and nitroglycerin were also tried for the erectile dysfunction. Of course, the surgical management, semi-rigid rod and mechanical rod, malleable devices, inflatable devices are all implanted into the shaft of the penis to get a permanent erection. They've got a pump outside, and if you just press it, it will get elongated, and if you do not want it, you just release it, this will come down. So this is the method, by surgical method, we can go for a penile erection. And homework assignment should be done for each and every patient, which I'm not going to deal because it's very tough to do. என்ன சொல்கிறாங்கன்னா, read erotic materials. See erotic materials in the books, movies, and go for it. And if the patient persists erection, he should not get answers. So many things which easy நம்ம டீச் பண்ண முடியல, ரொம்ப கஷ்டமாக இருக்கு. Don't try to be followed during the initial assessment, not to look for the erection. So patient பார்த்தீங்கன்னா மாத்திரை சாப்பிட்டு they'll just go and lie down in the bed and they will not involve in the sex. அவங்க மைண்ட் அங்கே கான்சென்ட்ரேட் பண்ண மாட்டாங்க. They'll just see only down whether the penis is getting erected. So these are all these things we can easily suggest to patient. And this is a DOT syndrome. This is a cultural bound disorder, anxiety and distress over the belief that semen lost through urination and nocturnal emission and other means leads to weakness and ill health. So semen is a vital substance. அவங்கள பொறுத்த வரைக்கும் DOT syndrome. இதுக்காகவே அவங்க they don't get the proper erection. And of course these drugs, metformin, pioglitazone, SGLT2, all these things are good, and clemencrimin is only drug which is not favorable for the erection dysfunction. And premature relaxation, ejaculation also, you can see the combination of pharmacological and non-pharmacological intervention is the most thing. And premature ejaculation drug of choice, sertraline, and retarded absent ejaculation also, cyproheptadine. The female sexual problems in diabetes. These are the things that you already told by the previous speakers. We had to assess and the blood flow for better arousal, orgasm, while topical estrogen treatments and addresses the vaginal dryness and the tissue health also. The psychological intervention should be also treated with the sex therapy, and the management can consider the depression, anxiety, and the maintaining of intimate relationships is mandatory. And this is the way the PD5 inhibitors also act in ladies, but only thing is not properly proven. What we need is we want a good amount of blood flow to the clitoral region so that they can also get the erection. So they can also get the orgasm. So in that way the PD5 inhibitors also is useful with the female, but much of studies are going on, it's not much proven. The hypoactive sexual disorder, we need to intervene the psychological management. The pharmacological interventions are apomorphine and hormonal treatment with estrogen and testosterone. Sildenafil is also much effective, and treat the other sexual dysfunction if at all present for the patient. Of course, the dyspareunia also, we can go for a sexual education, provide information about the suitable intercourse positions and progressive muscle relaxation exercise and positive self-talk and sensate focus. So after assessing the local pathology and the psychiatric problem to rule out everything, and as Madam already told, evaluate for possible local pathology, urinary tract infection, STD, episiotomy scar, endometriosis, and ovarian cyst. All these things are many hindrances for the dyspareunia in female patients. The strategies, if you look at it, the main thing, pharmacological intervention is osmiumefin, and vulvovaginal atrophy in postmenopausal women with vaginal dryness is useful for this drug. And you can see the flibanserin also, one of the drug responsible to act for the hypoactive sexual disorder, and the bremelantin also is useful for the premenopausal HSDD, and the testosterone therapy is not approved for use in females for sexual dysfunction. Of course, all these things, animal models, PD5 on vaginal and the clitoral tissues are similar in those observed in male. So nitric oxide synthase is active in the vaginal epithelium. So vaginal smooth muscle tissue and the clitoral shaft were much acted by the nitric oxide synthase also. The various PD5 inhibitors that have been evaluated in clinical trials in this population have included sildenafil, tadalafil, vardenafil, and all these other PD5 inhibitors also. Vaginal dryness, the prostatin also was tried, but it's not much effective. But anyway, this is another drug of choice for the vaginal dryness. So the complex interaction of effects involving both male and female. Conclusion: progress in medical care has led to a shift in diabetes care and brought in the issues of the quality of life in forefront. And sexuality, however, is an aspect of quality of life that has only recently gained more attention in the clinical care. So the take-home message: despite the fact that men with diabetes now have a host of options for addressing ED, the preventive education concerning the risk factors that lead to this disorder should be incorporated into diabetes management programs. Like any other pathies, the sexopathy should be given preventive care, and if detected early, should be given an aggressive treatment plan also. So, the sexual act is an act. Sexual act is an art. And so, train the patient who are ignorant of it, of course, verbally. And sexual dysfunction is a part of one of the complications of diabetes and a marker of CVD. And if we make ourselves thorough in diagnosing and treating sexual dysfunction, we can definitely prevent the cardiovascular event, because they both are coexisting. If a patient has got erectile dysfunction, definitely you have to go and assess for the cardiovascular event. Definitely they will be having some amount of vascular disorder in some part of the body. So all these things, if you properly treat, we can avoid, we can prevent not only cardiovascular disease, but also yes, we can avoid many divorces, and delay in justice is an injustice. Thank you.
Excellent talk by all the 5 speakers, led by my guru in academic side. Okay, so the question to Dr. Parandaman sir, you mentioned about all the hormones, sir. I just want to know about the oxytocin, as it is a metabolic regulator, the role of oxytocin in sexual dysfunction. Also, they're mentioning about the drugs causing sexual dysfunction, but we have been observing finasteride, sir. It's been used commonly for hair loss by young generation. So we are observing many patients presenting with sexual dysfunction. And the role of autonomic dysfunction, sir. Here, how are you going to go with sexual dysfunction, because there's more common orthostatic hypertension, how you detect and all this. Thank you.
Thank you, sir, for a wonderful question. And first is oxytocin. Oxytocin, otherwise called the love hormone. Anyone who have more oxytocin, they have more love with the opposite sex. And this is definitely important for the desire. Not only the testosterone is useful for the desire, in females, the oxytocin is essential for desire. And after this intercourse, that is, they will have the love and affection by the oxytocin. It's the release of oxytocin. So definitely oxytocin plays a role, but not in the phases, phase 1, phase 2, phase 3, phase 4, but prior and post. That's there. In males, oxytocin, it increases the contractility of the epidermis, vas deferens, and urethra. The expulsion is primarily done by the oxytocin. But it is a good hormone, but less when compared to the desire and other things, it is less effective, but it is essential for one other thing. Second thing is drug, finasteride. Finasteride, there are a lot of drugs. If you see the drugs, actually it is beyond my topic. Actually, I slightly entered into the others because of the case scenario I put, I could enter into that area, but it is not my area. But still, if you take the list of drugs causing erectile dysfunction, one of the commonly used, as you rightly said, is a finasteride. It is used for hair growth. And of course for the prostatic benign prostatic hypertrophy, that definitely it has decreased the testosterone levels and it decreases the desire. It should be cut down or it should be avoided in those young, especially younger individuals. Thirdly, autonomic dysfunction. By the time the patient develops autonomic dysfunction, the sexual dysfunction is severe. Whatever the medication you give, it may not work. Even if the process is very difficult. So that is a slightly late stage. Even though autonomic dysfunction can be the early manifestation of the diabetes, but if in reference to the sexual dysfunction, this is very, very difficult. Yes, it is a complex phenomena, especially cortex is primarily involved, followed by the parasympathetic. So it is very difficult to get the sexual function intact after once the patient develops orthostatic hypertension, parasympathetic. But ultimately that's what the primary aim of treatment is, control the blood sugar right from the beginning. If you want to prevent sexual dysfunction, you start even before he develops diabetes. That is in the state of insulin resistance. So insulin resistance is a main factor. It led to all levels, hypothalamus, pituitary, testis, and tissue level. So if you prevent that insulin resistance, probably this cannot come. Once this develops, probably difficult, and probably the last speaker, sir, will be telling that how to go about the autonomic, this thing and this thing. Thank you, sir. Sorry, sir. Glaucoma and ED, and of course it is a separate, but usually that I don't know whether it is a glaucoma directly related. Any hormones directly related, sympathetic, parasympathetic, and desire, these are directly related. Whether this, but diabetes can have glaucoma.
But drugs are contraindicated.
Drugs are contraindicated. Drugs are contraindicated, but whether the diabetes itself causing or dysfunction associated with glaucoma, we do not know. But diabetes will have glaucoma, drugs can cause glaucoma. So drug used in glaucoma should be avoided in erectile dysfunction.
Talks were excellent and very knowledgeable and very informative. Only one small information about female orgasm. In the rural areas, people do not know what is female orgasm. Most of the people who, I have been practicing for 56 years, and some of the rural areas where I practice, they say, is it a sexual intercourse, is it a pleasurable thing? We thought we are doing a favor to the husband because he is providing food, protection, looks after my children, everything is supplied by jewels, everything. So when he is tired, when he wants to relax, I want to help him to have sex, that's all. But only recently one of my sister's daughter told me that it also gives pleasure to us. How is it, doctor, she has asked. So many people do not know that there is a female orgasm for the men also. The partner satisfaction is the least important for them. Whatever they do, they just come and have a sex and then, completely come out and lie down and sleep within 1.5 minutes. They don't even know that there is a female orgasm and it has to be stimulated. The partner should be satisfied and other things are completely ignored. The next thing I just want to tell you is the infertility patients who are having that, during ovulation, the gynecologist said you should have the intercourse on those such particular days. This computer interview comes after a very tired work. The lady insists, today we should do it. That is the 5th ovulation time, like that. Then he has got ED. He doesn't do it at all. Because there is a congenial situation where the atmosphere must be clear, then only sexual. It is a pleasurable organ, it is not a duty. That is the thing we have to impart in our patients.
Yes, sir. The first question, sir. Not only in villages, but any part of the world, the ladies do not openly tell that they didn't get an orgasm. One of the main factors for this, as a previous speaker has given Parandaman has given a graph. The stages of the sexual act. You get an excitement stage, then you get a plateau, then you go for orgasm, and the stage of resolution. So these are the stages. For male, you get an excitement, the plateau stage is very short, and they get an orgasm immediately. But in female, they have an excitement, and the plateau stage goes for a very longer time. And they get a multiple orgasm. On one single time, they get a multiple orgasm. But for men, they got only one orgasm. After they spell out, automatically they will not have this. But ladies, they get more than 4 or 5 orgasms can occur in one single act. They got a longer plateau. That is why men are not able to satisfy the female in certain aspects. So we have to prolong the penetrative sex act for a longer time to get a satisfied sex for the female because of the plateau. Am I correct?
Yes, sir. As pointed out, the sexual life itself, talking about this is, we think it's a taboo and a stigma attached to it. So not only in the rural backdrop, even in, we get to see so many diabetic patients in our wards. We write a case sheet with the history taking, going for 2 pages, but nowhere I find any mention about the sexual desire, leave alone the female, even in the male. I don't think any mention about the sexual function is there. So we ourselves are averse to put a question which we think it's very personal. And as I said, the stigma attached to it. So when I think the female sexual dysfunction of late has to be addressed on priority basis, because this one issue is the major cause for all this middle life divorces, which is on the rise among the celebrities. Leave alone the general public, that it is not made public. But what we see, the celebrity divorces, this one part is the major cause, I think. And as said in andropause and menopause. Menopause, as one of the speakers who are talking about menopause was saying, it is an abrupt. It is not abrupt. It is a gradual phenomenon as in the male. But the only difference is it sets in earlier in the life of the female, whereas it takes almost the 7th or the 8th decade for an andropause to set in for the male. So this period, for a female, the menopause starts by 45 years. The perimenopausal period starts by 45 years, and for us, the male partner, it starts by 65. So this 2 decades is very crucial in the life of both the partners, which causes a significant impact on their quality of life. So I think the organizers have given due time to this important aspect, which is usually neglected in any conference. Leave alone all these sexual health conferences. In general part of discussions, this topic does not come into play.
I think we have to congratulate Shanmugam for making it as a symposium, because in every meeting they'll talk about erectile dysfunction for 15 to 20 minutes and leave it off. But this was a symposium. First, we have to give a very good applause for this. And secondly, Dr. Naran Reddy used to say, in the initial period of his practice, when he was practicing in Apollo, there was no case for him. Once they, in the master checkup, in the last thing was about the sexual health. Once they added this, then the cases started flooding. So I think so, at the end of our clinical thing also, you should ask. And in South India, first institute was Amrita Institute, who did prevalence of this ED in Amrita Institute for male and female. That was the first study. I think this is some 25 years back when they started the institute. So I think so in practice also, I think as Dr. Ravi told, the words are very, very important. What words you are going to use in this thing, that is very important. And with the due permission of the patient, we can discuss over the table and decide, I think so. So very good applause for this, and I would like to thank the speakers and the chairpersons for doing an excellent job.